محاضرة ثانية تتعلق بالتمرين for respiratory disease. The simple anatomy of the respiratory system is the first thing in the external of the nasal passage is the nose that have two cavities which is separated by nasal septum that lead to pharynx that have nasopharynx and oropharynx, and then to the larynx that have cartilaginous structure that go to the trachea is a tube, cartilaginous tube, not completely tube, that go to branches, the left and right bronchus, and then divided within the lung to many branches and end with alveoli. There are two lungs, right and left lung. The lung have loops. The right lung have 3 loops, and left lung have 2 loops. Within the alveoli, there are a mesh of networks that pass the blood from arterial blood to the venous blood. The arterial blood that have concentrated of CO2 that exchange within the alveolar cavity go the CO2 from blood to the cavity and the oxygen from the alveolar cavity to venous capillary and return as oxygenated blood. This figure shows the expiration and inspiration and automatic movement of within the chest cavity. The exchange of the gases that have the oxygen enter within the capillaries and go outside by the CO2. This figure shows how gas exchange that go the CO2 outside from the arterial capillaries and inside the O2 to venous capillaries. The most important diseases that related to respiratory system is chronic obstructive pulmonary disease. Chronic obstructive pulmonary disease is called as chronic obstructive pulmonary disease or called chronic obstructive airway disease. Is a chronic, slowly progressive, irreversible disease characterized by breathlessness, wheezy, airway obstruction, cough, and sputum production. The chronic obstructive pulmonary disease is most frequently a combination of 2 categories. The first one is called chronic bronchitis, and the second one is called emphysema. So it has 2 diseases that relate to chronic obstructive pulmonary disease. The chronic bronchitis is an excessive production of mucus and persistent cough with septum production daily for more than 3 months in a year over more than 2 consecutive years. This disease related to the trachea and the bronchi. So, if there are increased secretion of mucus that lead to decrease in volume of the trachea, that lead to have a cough and lead to a sputum production, and not all cough that called chronic bronchitis. There are certain criteria. This criteria is 3 months in 1 year, and for 2 years in continuous 2 years. So this is criteria that called chronic bronchitis. في هذا المريض اللي عنده كاف لفترات قصيرة وسنوات مختلفة ليس chronic bronchitis. This chronic bronchitis leads to production of excessive viscous mucus which is infectively cleared from airway obstruct and stagnate and become infected with Streptococcus pneumonia, Morcazilla catarrhalis, and Haemophilus influenzae. Patchy area of alveolar collapse can result. We can see in this figure how reduced the lumen by increased mucus secretion and stagnation of bacteria and lead to a bronchitis. The other categories is emphysema. What emphysema is a dilatation of airway space distal to terminal bronchiole with destructive or alveoli, reducing the alveolar surface area available for respiratory change. So, by a destruction of alveoli, this alveoli that lead to one alveoli also that decrease the size of respiratory surface for exchange gas. The most important cause of chronic obstructive pulmonary disease, the etiological factor, is cigarette smoking, environmental pollution, dust or occupation exposure to chemicals. Exposure to smoke from home cooking or heating falls may contribute. A deficiency of antiprotelectic enzyme alpha 1 antitrypsin, a rare cause of emphysema. This is the most common etiological factor of chronic obstructive pulmonary disease. The clinical feature, chronic obstructive pulmonary disease causes progressive dyspnea and low oxygen saturation. Accumulation of carbon dioxide leads to hypercapnia, acidosis, and eventual respiratory failure or right-sided heart failure called cor pulmonale. Both of the two categories of chronic obstructive pulmonary disease, that chronic bronchitis and emphysema, initially causes an early morning mucoid cough. This becomes mucopurulent during exacerbation. It is complicated by chronic hypoxemia with dyspnea on effort. It's only mild at first, but deteriorates to leave respiratory tribbles, dyspneic at rest, and especially when become orthopenic. This leads some patients with emphysema manage to maintain normal blood gases by hyperventilation to produce pink phantom or pink puffer, who is severely breathless, and pink bronchodilation caused by CO2 retention. Others, especially those with chronic bronchitis, fail to maintain hyperventilation. Loss of the CO2 drive become hypercapnic and hypoxic but less breathless. However, the chronic hypoxemia leads to central cyanosis, which in association with ankle edema and rise jugular venous pressure of cor pulmonary give rise to blue bloated appearance. For this patient, the respiratory drive is from the low PO2 and thus oxygen administration is contraindication. In chronic obstructive pulmonary disease, the sequence of pulmonary hypertension lead to right ventricular hypertrophy and cardiac failure called cor pulmonale eventually develops. How we manage the patient have chronic obstructive disease? We start from the diagnosis. The diagnosis is confirmed by chest radiography, respiratory function test, is spirometry, and arterial blood gases examination and laboratory investigation. The forced expiratory volume in 1 second is typically reduced and is used to grade chronic obstructive pulmonary disease. A ratio of the forced expiratory volume vital capacity is of less than 70% confirmed airway obstruction, and the forced expiratory volume in 1 second of less than 40% is the mark of severe chronic obstructive pulmonary disease. The blood gases should be measured if pulsy oximetry show an oxygen saturation less than 92%. The normal saturation of oxygen is between 96 to 98. So if reduced than this normal, become less oxygen within the blood. Patients with chronic obstructive pulmonary disease must stop smoking and, where appropriate, nicotine replacement therapy or warfarin amphetamine may help. The exacerbation of bronchitis are managed with antibiotics such as amoxicillin, trimethoprim, or tetracycline. The most important due to the bacterial infection, so need antibiotics. The immunization against influenza is recommended. Mucolytic such as carboplatin reduce acute exacerbation by almost 1/3. Breathing may benefit from use of bronchodilator. The epinephrine bromide, other antimuscarinic like oxytropine or beta agonists, or occasionally low-dose inhaled or systemic corticosteroid or theophylline. Long-term oxygen therapy may be needed, mainly in emphysema. Severe cases are occasionally treated with surgery, polyectomy, or lung transplantation, and it is rarely used in this day. The difference between emphysema and the chronic bronchitis: the cough in emphysema is minimal, but in chronic bronchitis, chronic cough, sputum in emphysema minimal, and pupils and mucoid that have lead to stagnation of bacteria and lead to bronchitis. Infection is uncommon, but it is common in chronic bronchitis. Dyspnea is severe, that have increase in CO2 level, and it is mild in chronic bronchitis. PO2 level is low in both disease. BCO2 level normal in emphysema but rise in chronic bronchitis. Forced expiratory volume in two diseases are low. Clinical appearance in emphysema is pink panther, but in chronic bronchitis is blue flutter. How we dental management of patients have chronic obstructive bronchitis. The modification of treatment: patients with chronic or obstructive pulmonary disease are best treated in the upright position, as they may become physically breathless if late cut. It may be difficult to use rubber dam, as the patient may not tolerate an additional obstruction to breathing due to its difficulty breathing by nose. So the rubber dam can close the mouth, so it is difficult to lead to obstruction to breathing. Patient taking corticosteroids should be treated with appropriate precaution. So if patient have taken a prolonged period steroid therapy, need appropriate precaution for them before treatment of dental management. Interaction of theophylline with drugs such as epinephrine, erythromycin, clindamycin, azithromycin, the clarithromycin or ciprofloxacin may result in dangerously high level of theophylline that have not excretion. The theophylline and increase the concentration within the blood. Local anesthesia is preferred for dental treatment, but bilateral mandibular or palatal injection should be avoided due to paralysis of the muscle of fish mastication and need to have muscle of that within the larynx that have it's dangerous to give it the bilateral block. Patient with chronic obstructive pulmonary disease should be given relative analgesia only if absolutely necessary, and only in hospital after full preoperative assessment. Diazepam and midazolam are mild respiratory depression and should not be used any drugs that lead to depress the respiratory center in the outside of the hospital. Patients with chronic obstructive pulmonary disease should be given a general anesthesia only if absolutely necessary, and only after full preparation, pre-operative assessment. So need special preparation and must consultation with the anesthetist to give general anesthesia in hospital. Intravenous barbiturates are totally contraindication, and in all type of antidepressant drug that have contraindication for patient have obstructive pulmonary disease. The secretion reduces airway patency, and if light anesthetize, the patient may cough and contaminate other area of lung. Post-operative respiratory complications are more prevalent in patients with pre-existing lung disease, especially after a prolonged operation and if there has been no pre-operative preparation. Most patients with pre-existing respiratory disease present no problem if assessment and anesthesia have been managed appropriately. Spirometry and carbon monoxide perfusion are essential to assess respiratory function. The most important single factor in preoperative care is cessation of smoking for at least 1 week preoperatively. Respiratory infection must also be eradicated. So you must stop any smoking for at least 1 week. For culture and such as amoxicillin should be started without awaiting results. So, initially, the result is and give appropriate sensitive antibiotics. This figure we can see in the previous لحد عام 1990 تقريبا أو أكثر كانت الكرونيك obstructive pulmonary disease يشمل disease هي chronic bronchitis, emphysema as asthma. But now in new textbook the asthma is a disease that's not related to chronic obstructive pulmonary disease. Now what have the second disease is asthma. What is asthma? Asthma is bronchial. Asthma is a state of bronchial hyperreactivity causing a paroxysmal expiratory wheezing, dyspnea, and cough. Generalized reversible bronchial narrowing is caused by excessive bronchial smooth muscle tone, lead to bronchospasm, the mucosal oedema, and congestion and mucus hypersecretion. These three categories that lead to asthma by bronchospasm of the smooth muscle that around the trachea with mucosa that have increased in size and lead to edema and congestion and stagnation of mucus and due to hypersecretion of mucus within the trachea. There are also a diminished ciliary clearance. The no trachea is a cilia that with a columnar cell of epithelium. So if it is diminished, so the foreign body can enter to the lung. The pathology of asthma. We have normal airway and then the construction of smooth muscle and with the increased secretion of mucin that reduce the size of the trachea or the bronchi or bronchioles that have into asthmatic airway during attack. The normal airway that have reduced the alveolar trap of so reduce the air that enter to the alveoli. Asthma is common disease, affects from 2 to 5% of population. It is more common in male and usually begin in childhood or early adult life. About half the patients with asthma develop it before age of 10 years. So in childhood is more common asthma. We have two types of asthma, the extrinsic type and intrinsic type. The extrinsic type is the allergic type, may be precipitated particularly by allergy in the host dust, animal dander, feathers, animal hairs, molds, milk, egg, fish, fruit, nuts, non-steroidal anti-inflammatory agent, and some antibiotic, and is the typical asthma in children. This asthma is allergic type and it occurs in mast cell production that cause bronchospasm and edema. Then, by time the child can be healthy and within recovery type of asthmatic type. But mediator involved including histamine, leukotriene, prostaglandin, bradykinin, and platelet activity factors that lead to an asthmatic attack. The second type of asthma is interstitial asthma or not allergic asthma in nature and appears to related to mast cell instability and hyperresponsive airway. It is triggered mainly by emotional stress, gastroesophageal reflex to have and not need allergy to produce the type of asthma. The episodes of either type of asthma can sometimes be initiated by infection, especially viral, mycoplasmal, or fungal, irritating fumes, including cigarette smoke, exercise, possibly due to the cold air, weather change, emotional stress, foods such as nuts, shell, uh, shellfish, strawberries, or milk. Particularly aspirin and other non-steroidal anti-inflammatory drugs, beta blocker, and ACE inhibitor up to 20% are reactive of non-steroidal anti-inflammatory drugs. هذه هي أهم etiological factors that lead to asthma. This is the allergic type, and the allergen is many in the world that have entered to the trachea and lead to asthma. The clinical feature of asthma is first dyspnea, cough, wheezing, and labor expiration are prominent in children with asthma initially suffer from repeated colds with cough. Malaise and fever are often at night. Nasal polyps are common, especially in aspirin-sensitive asthmatics. The frequency and severity of attack vary widely between individuals. Rarely prolonged and often life-threatening attack refractory to treatment start, and if this persists for more than 24 hours. The causes of intrinsic idiopsychotic. The frequency is most common in return the attack, but in intrinsic less common. Associated with atopy, it is in extrinsic that have due to allergic due to presence of IgE-mediated mast cell degranulation. The age of onset in intrinsic in child and intrinsic in adult. Precipitate in dust, animal dander, feathers, animal hairs, mold, milk, egg, fish, fruit, nuts, non-steroidal anti-inflammatory agent, and antibiotic. And intrinsic emotional by doing certain investigation like chest radiography, skin test, which may help to identify an allergen in mainly in child, and that blood examination usually rise into IgE and specific IgE antibodies concentration. The laboratory investigation is spirometry is particularly important for asthmatic patients. This is the chest X-ray. She shows the distribution of radio orbit within the lung space that have an asthmatic patient. How treat of the asthmatic patient treatment should be based on the amount by which peak flow is reduced. Occasionally, with histamine or methamphetamine challenge is used if the diagnosis is unclear. Management of asthma includes avoidance of unfavorable use of drugs, home use of There are daily symptoms of asthma. Beta agonists may be added to give symptomatic relief. If there are many attacks within a day, so it is very important given a steroid therapy. 3. Leukotriene receptor antagonist, omalizumab, and recombinant humanized monoclonal anti-IgE antibody that cause reduction in total serum IgE in topic patients, which tends the amount of antigen-specific IgE that can bind to and sensitive tissue mast cell and basophils, and in turn lead to decrease in symptoms of asthma. Systemic steroids and oxygen and hospitalization may be indicated in recalcitrant disease that in severe cases of asthma that must enter to the hospital and give him a fresh oxygen with systemic steroid therapy. The deaths from asthma are usually a result of failure to recognize deterioration or resistance to use the corticosteroids. The death not due to asthma but due to the steroid therapy that taking fibrillation. Asthma incidence, morbidity, and mortality continue to rise significantly despite significant scientific advance and improved understanding of the disease and ability to render effective treatment. We have three types of asthma according to severity. We have mild, moderate, severe. The symptom duration is less than 1 hour in mild, but in moderate within days, but severe resistant for long period. Attack frequency per week, we have less than 2 attacks per week. We have more than 2 attacks per week in moderate and in severe persistent for down than in a week. Other comment in mild attack flow, exercise or exposure to triggers, and moderate activity restricted, in severe iodable wheezing, tachypnea, activity and sleep severely restricted. The typical treatment or typical therapy for mild beta agonists are required in moderate beta agonists plus steroid, in severe beta agonists plus steroid plus theophylline. How manage patients have asthmatic disease? The asthmatic patient should be asked to bring their usual medication with them when combined for dental treatment. Mainly salbutamol inhaler is very important. If attack that occur in the patient have asthma, can give an inhaler to treat him and continuous management. Elective dental care should be deferred in severe asthmatic until they are in better phase. In case of severe asthmatic, not given any dental treatment except the as drainage of the pus from the dental pulp, or give him a simple treatment for reassurance with asthmatic attack after the patient comes better, that continuous management. Allergy to penicillin may be more frequent if the patient have allergy, more frequent to have an asthmatic attack. Interaction of theophylline with epinephrine, erythromycin, clindamycin, azithromycin Clarithromycin ciprofloxacin may result in dangerous high level of theophylline in the blood. Patients on leukotriene modifying drug may have a prolonged interleukin INR and bleeding tendency because of impaired liver metabolism. Systemic steroid therapy brings with its risk from a steroid complication, and operations are dangerous on such patients without adequate preparation. Drugs to be avoided with the patient have asthmatic patient since they may precipitate an asthma attack, including particularly this drug, like aspirin and non-steroidal anti-inflammatory drug, increase serum the rapid relocates level. Sulfite in local anesthesia. Local anesthesia is best used for dental treatment, not is contraindication due to the presence of vaso construction that lead vasodilatation of trachea. Occasional patients with asthma may react to sulfites present as a preservative in vasoconstrictor containing local anesthesia. It may be better where possible to avoid solution containing vasoconstrictor. If epinephrine-containing local analgesia are indicated, they should be given with aspirating syringe, since epinephrine may theoretically enhance the risk of dysrhythmia with beta agonists. Epinephrine is contraindication in patients using theophylline as it may precipitate dysrhythmia. The conscious sedation. Relative analgesia with nitrous oxide and oxygen is preferable to intravenous sedation and give more immediate control of asthmatic patients. Sedatives in general are better avoided as in acute asthmatic attack. Even benzodiazepine can precipitate respiratory failure. General anesthesia. General anesthesia is best avoided may be complication by hypoxia and hypercapnia, which can cause pulmonary edema, even when cardiac function is normal, and the cardiac failure if there is cardiac diseases. The risk of post-operative collapse of the lung or pneumothorax is also increased in asthmatic patients. Halothane or better influence isoflurane, distal or sevoflurane are the preferred anesthetic, but ketamine may be useful in children. An asthmatic attack may be precipitated by drug causing histamine releasing directly through for morphine and some other opioids, methotrexate, thiophenytoin, and salmeterol. Tubocurarine and panocuramine should therefore be avoided for patients who have asthmatic disease. The use of steroid therapy inhaler occasionally causes oral or pharyngeal rash and rarely angina and pulsa bullosa hemorrhagica that have within the mouth and the oral cavity that patient taking a steroid inhaler. Beta-2 agonists and ipiratomine bromide can cause a dry mouth. Anti-asthmatic drug may lower the salivary pH. Periodontal inflammation is greater in asthmatic than in those without respiratory disease. Gastroesophageal reflux is not uncommon with occasional tooth erosion. The other last disease with respiratory system is tuberculosis, the most infectious disease led by tuberculosis bacteria. A person may contract pulmonary tuberculosis from inhaling droplets from a cough or sneeze by an infected person that lead to granuloma in lung tissue, not specific granuloma of the lung tissue. Tuberculosis is caused mainly by infection with Mycobacterium tuberculosis as a primary disease of respiratory system. The pulmonary tuberculosis is the main tuberculosis in the body in the lung. Tuberculosis from microbiome milks have been virtually eliminated by tuberculin testing of castle and pasteurization of milk that have stopped the growth of the tuberculosis disease. Tuberculosis may also be caused by other non-tuberculosis atypical microbacteria. Non-typical microbacteria as Mycobacterium avium complex that lead to tuberculosis. We have pulmonary tuberculosis usually transmitted by infective symptoms, typically from close contact such as family member. لهذا يجب أن نتجنب أي الاختلاطات القوية بالمجتمع خاصة اللي عندهم respiratory disease لأن احتمال التي بي ينتقل عن طريق الرذاذ. About 10% of those infected develop overall disease of this half will manifest within 5 years primary tuberculosis. The remainder will develop post-primary disease, so only 10% have an symptom and sign and symptom of disease of TB. TB is unlikely to be transmitted between normal social contact. It is not spread by touch or by drinking glasses, dishes, sheets, or clothes. Tuberculosis is a major global health problem. 1/3 of the world population is infected. لهذا يعتبر من الأمراض الشائعة في العالم هي التوبركلوسيس. رغم أنه تحددت في مكانات مختلفة بس لحد الآن منتشرة في الدول النامية في العالم. It is particularly widespread in developed countries and some 2 million people die annually from tuberculosis. It's also a disease especially for immigrants such as those from Indian subcontinent and Southeast Asia. Tuberculosis is spreading worldwide. Highest rise in incidence are in South Asia. في هذا الانتقال الهجرة المجتمعية من الهند وشرق آسيا إلى دول أوروبا وأمريكا أدت إلى انتقال التي بي إلى هذه الأمراض هذه المرضى. In developing countries, the incidence is also rising properly because of worsening social deprivation, immigration, HIV infection, and intravenous drug abuse. هذه الحالات تؤدي إلى زيادة التوبركلوسيس. It is and now as common in London as in the developing world. الهجرة الهنود وشرق آسيا إلى لندن أدت إلى حدوث التوبركلوسيس في بريطانيا. In the developed countries, tuberculosis mainly affects medically neglected persons such as vegetarians, alcoholics, or elderly who are homeless. في شرق آسيا وفي الهند خاصة أعمارهم كبيرة لا يكونون في بيوت مع أهلهم فلهذا أكثر عرضة للتوبركلوز. المدمنين على الكحول النباتيين أيضا أكثر عرضة للتوبركلوز. The immunocompressed such as diabetes, severely immune-modification patients such as those with HIV infection, human immune virus infection, and the patients rising or institutes such are also at risk. The organism is then frequently multi-drug resistant. It is the difficult treatment by single antibiotic. The persistent medical and live infection that is disseminated. Intravenous drug abuse are particularly effective. حقيقة انتقال tuberculosis microorganism by the intravenous drug abuse. So it's very dangerous and patients are taking the same needle and can each person so can transmit tuberculosis for the healthy patient. Patients with HIV infection frequently also develop tuberculosis due to non-tuberculosis atypical microbacteria. We have typical microbacteria and atypical microbacteria. الاتيبيكال مايكروبكتيريا التي تحدث الاشخاص اللي عندهم HIV infection, and this lead to antimicrobial resistance spreading. Tuberculosis present and occupational risk للclinical staff. حقيقة تقل بسرعة التوبركلوسيس في العمل في عيادات. The clinical feature of tuberculosis, most primary infection in normal person are subclinical. After mycobacteria have entered the body defense usually refers them to the main barrier. Person infected but not ill are unlikely to know that they are infected. Inhaled mycobacteria may cause subpleural lesion and interregional lymph nodes primary complex. However, in a massive infection, acute active mycobacteria may multiply that have these. There are other parts of body that occur have tuberculosis, like in the immune system, in genital tract, in the bone, in joint, or eye. Lymph node tuberculosis lead to lymphadenopathy, causation of node and pressure septum, for example, on bronchial, because it frequently passes unrecognized for so long. The mortality from pulmonary TB is high. How we manage patients start with the diagnosis of tuberculosis suggested by history of and confirmed by. إذا نبدي بالhistory do this physical examination, tuberculin testing, Manatox or HCAF test by skin test for a delayed hypersensitivity reaction to protein from the mast cell. Tuberculosis, pure protein derivative that are neither 100% sensitive nor specific. Positivity indicated infection, but not necessarily that the infection is active. Polymers chain, the previous smear and culture and polymers chain reaction technique have lately accelerated the diagnosis and specification of mycobacteria, but Ziel-Nielsen, uramine, or rhodamine stain are still used in diagnosis of the tuberculin test. A specimen of sputum, laryngeal swab, broncho, after lavage, gastric aspirate, or pleural fluid may be tested for presence of Mycobacterium in the specimen. The mycobacterial growth indicator tube system give result as early between 3 to 14 days. How treatment of the tuberculosis. The first priority of tuberculosis control programs is identify and completely treated all patients with active disease. People who should be treated for tuberculosis include those who have had a symptom of the tuberculin infection and have had close day-to-day contact with active tuberculin disease family member, friend, or coworker have HIV infection or lowered immunity of patient during tuberculosis. The antibiotic chemotherapy is indicated for people who are sick with tuberculosis, infected but not sick, close contact to infected tuberculosis cases regardless of age. Treatment is started with 3 antibiotics. There are triple antibiotics given for tuberculosis, and its combination to avoid the emergence of bacterial resistance due to its high resistance from single antibiotic. So the triple antibiotic is very important for the treatment of tuberculosis. Drug can be given as a single daily dose with food. The chemotherapy must be given for at least 6 months, 9 months in the immune compressed to be effective. Initial therapy of tuberculosis is intense with daily ionized rifampicin and pyrazamide or ethambutol for 2 months. And the 4th month, pyridoxine is given to prevent ionized-induced peripheral neuropathy. Rifampicin interferes with the contraceptive pill. Alcoholics, drug abusers, vagrant people with learning disability, or those with psychiatric disorder frequently default from treatment, and if chemotherapy is less than adequate, bacterial resistance readily develops. The continuation therapy of tuberculosis is with daily ionized and rifampicin for further 4 months. So we start with triple therapy and for 2 months and continuous for 4 months by 2 antibiotics. Patients are infectious until symptom is negative to culture, but infective is greatly reduced by 2 weeks after the start of chemotherapy. Chemoprophylaxis with ionized and rifampicin is indicated when there is previous inadequate treatment of tuberculosis, close contact with person activity infected with tuberculosis, conversion of tuberculin tests within the past 2 years, positive tuberculin tests in the following group. This group includes immune suppressive persons as like diabetes, renal failure, cancer, and HIV infection. The person under 35-year-old, intravenous drug users, a foreign-born person who has migrated from a region of high prevalence within the previous 2 years, immunization using BCG, basal, candidosis give some protection but is not highly reliable. The drug that used for tuberculosis is the main antibiotic like isoniazid and pyrazinamide and rifampicin, intravenous acetoamycin. The analgesia is used in initial therapy and continuation therapy. Main side effect is peripheral neuropathy and hepatotoxicity. Pyrazamide is used in initial therapy and the main side effect is hepatotoxicity. Rifampicin, initial therapy, that main side effect urine and saliva turn red, the bullous lesion. Continuous therapy that have main side effect is enhanced liver drug metabolizing enzyme, hepatotoxicity, nephrotoxicity. The ethambutol is used in initial therapy and the main side effect ocular damage. Cetromycin is used in initial therapy and the main side effect is vestibular nerve damage, circumoral paresthesia. What to do for dental management if patient have tuberculosis? Management depends on the level of patient infectivity. The tuberculosis is unlikely to transmit it to start during oral health care unless the person being treated has active pulmonary tuberculosis or the dental staff are immune compromised staff. Patients with open pulmonary tuberculosis are continuous and dental treatment is thus best until the infection has been treated. Identifying appropriate treatment for every person with active tuberculosis is highly important component of control strategy. Pulmonary tuberculosis of high infectivity if patient with open pulmonary tuberculosis. Precautions should be used to prevent the release of mycobacteria into the to remove any that are present and to stop inhalation by other persons. Reduction of splatter and aerosol by minimizing coughing and avoiding ultrasonic instrument and use of rubber dam are important. Improved ventilation, ultraviolet germicidal light, new masks and personal respirators and other personal protective devices such as high efficiency particulate air filter are indicated. Mycobacteria are very resistant to disinfecting, so heat sterilization should be used whenever possible. Other factors such as alcoholism or intravenous drug use, hepatitis, or HIV disease may also influence the local anesthesia is safe and satisfactory. Relative analgesia is contraindication because of risk of contamination of the apparatus. General anesthesia is also a contraindication for dental treatment because of the risk of contamination of the anesthetic apparatus or because of impaired pulmonary function. Immunoglycosides such as streptomycin enhance the activity of some neuromuscular blocking drugs in large dose may alone cause myasthenia syndrome. Drug interaction within the antibiotic that used with the tuberculosis, like the clearance of diazepam and hepatotoxicity of acetaminophen, are enhanced by rifampicin. Acetaminophen should be avoided in patients on ionized because of the enhanced hepatotoxicity as all antifungals interact with rifampicin, clarithromycin interact with rifampicin, benzodiazepine interact with rifampicin. Aspirin should be avoided in patients on streptomycin, amikacin, kanamycin, or cypromycin. Chronic ulcers, usually on the dorsum of the tongue, are the main oral manifestation of tuberculosis. They result from coughing of infected sputum from pulmonary tuberculosis, including HIV-infected persons with tuberculosis, but are rare. Occasionally, the diagnosis of pulmonary tuberculosis is made from biopsy of an oral ulcer after regular mass are seen in microscopically. Acid-fat bacilli are rarely seen in oral biopsies, even with the help and special stain. Such cases, usually middle-aged males, may result from neglect of symptom or adult default from treatment. Antibiotic material should also be sent for culture if possible. However, the diagnosis needs to be confirmed by sputum culture and chest radiography. Tuberculosis, cervical lymphadenopathy, is the next most common form of the infection of pulmonary disease. Most tuberculosis lymphadenitis is painless with several enlarged matted nodes, but systemic symptom only and minority and only 50% have pulmonary manifestation on radiography. Diagnosis release on tuberculin test, but this can be positive in both tuberculosis and lymph node NTM cervical lymphadenitis. Any person with lymphadenopathy and relevant conversion from a negative to positive tuberculin test should be suspected to have mycobacterial infection, and this should promote biopsy, such as fine needle aspiration biopsy for culture or histological confirmation. Polymers chain reaction with improved diagnosis as culture must wait 4 to 8 weeks for the result. The NTM are relatively common cause of cervical lymphadenitis in children under 12 years and in HIV diseases. Topical corticosteroids for use in mouth are unlikely to have any systemic effect but predispose to oral candidosis. Susceptibility to infection is increased by systemic steroid use, and there is a predisposition to herpes virus infection, particularly herpes simplex. Chickenpox is a special hazard to those who are not immune, and filament disease can result. Passive immunization with varicella zoster immunoglobulin is indicated for non-immune patients on systemic corticosteroids or who have been on them within the previous 3 months. If exposed to chickenpox or zosters, immunization should be given within 3 days of exposure. Candidosis and bacterial infection also tend to be more frequent and severe in tuberculosis patients. The oral complications of antitubercular therapy are rare, but rifampicin and rifampicin can cause red saliva. This table shows the management of patients with non or suspected tuberculosis, history of tuberculosis, potential infectivity, and the most common comment that have given to the patient. Active sputum positive tuberculosis is a highly infectivity and defer elective dental care until tuberculosis treatment complete or use special effective infection control precaution. Recent history of tuberculosis and sputum non-positive for tuberculosis is potentially effectively high and elective dental care until tuberculosis treatment complete or use special infective control precaution. Past history of tuberculosis need confirmation that need a test for improved presence of tuberculum microorganisms. The comment defer elective dental care until medical device received. No history of tuberculosis, but a sign or symptom of suggestive needle confirmation to needle aspiration biopsy, and if comment defer elective dental care until medical advice received, use special effective control precautions for emergency dental care. No history of tuberculosis, but positive tuberculin test need confirmation with a physician. They defer effective dental care until medical advice received. Use special effective control precaution for emergency dental care. Thanks for listening. If any question answered by model or any classroom or أي وسيلة اتصال تتصل بها وأقدر أجاوبك على أي سؤال.